Good afternoon, and I'll basically be talk to you about the rescue of a failed filter. I mean, a failed filter obviously you cannot rescue. I have no financial interest in the subject matter of the presentation. And typically, in a failing bleb, the reasons for this are scarring that occurs at the subconjunctival area, the subscleral flap, or at the ostium. And there are a few things that do to try and address this. Now, if it is conjunctival, the options that have are either a needling or 5-fluorouracil injections, and what we typically give is 50 micrograms per milligram per ml, given about 0.1 ml 90 degrees away. Even though it's classically described that you give it 180 degrees away, in my hands 180 degrees away doesn't seem to do anything, so I give it 90 degrees away, and I tend to repeat it every day for a period of maybe up to 5 to 7 to 9 days. You have to watch for corneal toxicity because it can cause superficial punctate keratitis. The first case that I have, this is 55-year-old pseudophakic lady with advanced open-angle glaucoma, 3 weeks post-trabeclectomy with mitomycin. It was done with 1 releasable and 2 interrupted sutures. Intraocular pressure was 8 millimeters of mercury, which came down with massage to 16 millimeters of mercury. But this is very important because if you get that sort of drop with the massage, that tells you that your flap, there is still enough filtration happening. It's just that the flap is not allowing fluid to filter out of the eye. So one of the options you have here is you have a releasable suture there, so you can just pull out that releasable suture, which are pretty easy to do. And with that itself come down, then you attempt massage. Because even taking releasable can drop your pressures to 0 or 2 millimeters of mercury, and if you do a massage at that point, you're going to land up in trouble. So 1 week post releasable, her intraocular pressure was 26. On massage, it was again coming down to 16. So in this situation, now we have 2 fixed sutures and 1 releasable on the flap. It's about 4 weeks after surgery. We have taken 1 releasable. We still are not getting pressures that we want, but the pressures are reducing on massage. So the option you have over here is, this is post massage. This is what she looks like. So you have a fairly decent sort of with the massage, and you know that if you can somehow get a little more aqueous to flow through, you can probably escape. Okay, I think I've.
1 second.
My videos have gone?
No, I have to click on.
Okay, anyway, I'll show you the video towards the end. The second patient, no, it's okay, let it be. So the first patient, essentially what we did was an argon-lesson suture lysis. I'll show you the video, it's sitting somewhere else. The second patient we had was post-phacotrab for pseudoexfoliation glaucoma. 8 weeks post-op, pressures are 30, with massage dropped to 28 millimeters of mercury. So here what you know that at this point, you are dealing with either subconjunctival fibrosis or subscleral fibrosis, because the massage is not helping in any way. And this is what that eye looked like. With pseudoexfoliation, it is at high risk for failure, and it's also going to be refractory to medical therapy. We're only 8 weeks post-op, so you can try to needle it. I believe Rajul has shown this video before, but before you do anything there, you need to confirm that the reason is not a blockage at the ostium. So if your ostium is patent, then you go ahead and you can attempt this procedure. Essentially, it's with topical anesthesia with standard aseptic precautions. Use a 30 gauge needle. Anywhere between 24 to 30 gauge has been described, but we typically go with 26 or 30 gauge. Use a tuberculin syringe, and we typically inject 5 FU with the after the procedure. Mitomycin has also been described, and I believe Rajul uses mitomycin. The difference between what you want to do over here is you have these sort of adhesions which are under the bleb, and with your needle you go with back and forth movements to break them up and gently advance the needle so that you can see that those adhesions get broken up. And if required, if that doesn't help you to bring the bleb up, then you know that the problem is not only subconjunctival fibrosis, you probably have a subscleral element too. Then you try and go under the scleral flap and try and elevate that. You have to make sure that you have reasonable visualization, because it's possible to poke that needle into all sorts of places otherwise. And if you have already seen the video, I won't go over it again.
Needling of bleb. Cotton tipped applicator soaked in topical anesthetic is applied over the injection site. 30 gauge needle is used to enter the bleb away from the actual bleb site.
Anyway, it doesn't matter. So basically, you're using, in addition to we are attempting to go subscleral. And that's where the direction is in that way. And there is a little bit of resistance. At this point, the globe is a little hypotenuse. So you make sure that you form the AC, because you want the globe to be reasonably firm before you give the 5FU injection after surgery. Otherwise, the 5FU can cause your endothelium to wipe out. And we typically patch for a few hours so that whatever little ooze level site goes up, and give topical steroids. And let me just see whether I can show you that the argument is, yes, it's there. You use a 50 micron spot, and you use settings of 200 millisecond duration and about 100 milliwatts. Depending on your laser, lasers have got older, we have had to use longer Mendelcon lens. If you don't have access to a lens and occasionally do the procedure, you can use the corner of a 4 meter gonioscope, and you essentially use that lens to indent onto so that you press it and you squeeze out the thing. And so we've given 2 shots there, and you can see that suture has separated. So it's essentially, don't immediately do anything to the eye. See the patient again after an hour, and typically don't do more than 1 light slices. Also, you can land up with hypotony and terribly, choroidals, the entire work. So thank you, and if any questions, I'll be happy to take them.